Welcome to the 2025 Quality Measurement Program training for Oregon's residential care and assisted living facilities. I'm David Berger, the program coordinator. I'll be guiding you through how to track and report your data for the 2025 calendar year. This training is designed to help you get it right the first time and avoid common reporting pitfalls. Before we get started, let's walk through what you can expect to learn today. By the end of this training, you should be able to understand why quality measurement matters, not just to ODHS, but to residents, families, and facility teams. Accurately track and report each of the required metrics. Know when key deadlines are and what's required for compliance. And apply best practices to improve data accuracy, which helps ensure your facility's performance is reflected clearly and fairly. The Quality Measurement Program was created by the legislature in 2017. The process began with the governor-appointed Quality Measurement Council, defining the metrics provided by the legislature. The council is comprised of 9 members: a representative from the Oregon Patient Safety Commission, a representative for assisted living and residential care facilities, a representative from an Alzheimer's advocacy group, a medical practitioner with experience in geriatrics, 2 academics who perform research in aging, the state long-term care ombudsman, and a representative for direct care workers. The legislature set up the council to bring experts with different experiences in aging, long-term care, and quality improvement. Their ideas help decide how to measure and improve the care people receive. Before we dive deeper into the individual metrics, it's important to pause and talk about why quality metrics matter, both to facilities and to the state. Participation in the Quality Measurement Program is required by Oregon law for all licensed residential care and assisted living facilities. This isn't optional. It's a legal requirement. However, the program is non-punitive, meaning the information you report will not be used as the basis for citations or regulatory action. As long as your facility submits the required data, you are meeting the rule, even if the results show room for improvement. The system is also designed to promote transparency and accountability. These aren't just numbers for regulators. They help the public, prospective residents, and their families understand how facilities are performing. The data we collect feeds into the annual report and policy decisions. So what you submit doesn't just affect your facility, it helps shape the future of care in Oregon. But beyond the legal requirement, this work really helps facilities improve resident care and safety. It gives providers concrete data they can use to identify what's working and where there's room for improvement. And finally, non-compliance has consequences. Facilities that don't report can face penalties, including being flagged in public reporting. So the bottom line is, these metrics help us work together toward better outcomes for residents, more informed oversight, and a stronger long-term care system across the state. Here's a quick overview of the 6 quality metrics included in the 2025 report. Each one is designed to measure a specific aspect of care quality, safety, or resident satisfaction. Together, they help us understand how facilities are doing and where improvements might be needed. Let me walk you through each one briefly. Metric 1, retention of direct care staff. This tracks how many of your direct care staff stayed on for the entire calendar year. Retention matters because stable staffing supports better continuity of care. Metric 2, compliance with on-time staff training requirements. This includes all staff, not just direct care workers, and covers required training completed on time throughout the full year. Training helps ensure staff can provide safe, effective care. Metric 3, resident falls with injury. This focuses on falls that occurred between June and November 2025 and resulted in an injury. Falls are a major safety concern and a leading cause of harm. Metric 4, antipsychotic medications prescribed for non-standard use. This looks at prescribing patterns in October 2025 to assess how often antipsychotics are used outside of standard clinical guidelines. It's an important measure of medication safety. Metric 5, Resident and Family Satisfaction Survey. This metric captures feedback using a standardized survey. For memory care facilities, we've added a new component this year, a separate family satisfaction survey in addition to the resident survey. Metric 6, Administrator Tenure. This is also new for 2025. It tracks how long the administrator has served without the facility needing to report any additional data. Research shows that leadership stability supports stronger teams and better outcomes. These 6 metrics reflect different angles of quality, from staffing and training to resident experiences and safety. Before you begin reporting your 2025 quality metrics, I recommend reviewing these 4 key documents found under Quick Links on the program website. Each one is designed to walk you through the process and help ensure your data is complete, accurate, and submitted on time. Let's quickly go over them. The 2025 Provider Instructions for Data Collection. This is your roadmap. It outlines how to report each metric. It also contains critical reference tables for Metric 4, specifically a list of antipsychotic medications and a list of exclusionary diagnoses. You'll need to refer to these tables to ensure your data entry for Metric 4 is valid. Data collection instructions and screenshots. This gives you a visual walkthrough of the reporting portal and what data fields you'll need to fill out. It helps reduce surprises and makes the online process more predictable. 2025 QMP Data Worksheet. This is your worksheet. Complete this offline before entering anything into the portal. It's the best way to catch mistakes early and retain a copy of your data. 2025 QMP Training Presentation Handout. This is a copy of today's PowerPoint slides. It's perfect if you want to revisit the training later or share it with others on your team who couldn't attend. All of these resources are available on the QMP program website. Bookmark the site or save it to your favorites. You'll return to it throughout the year for resources, updates, and access to the data reporting portal when it opens. These tools are here to make reporting easier, clearer, and more consistent. Don't feel like you need to memorize every metric. Just know where to look when you need support. Not only does the data worksheet keep you organized, on the worksheet, each metric includes quality checks, like making sure one number isn't higher than the total it's a part of. If those checks aren't met, your submission will be marked as reported, not valid. And here's the key. That label shows up in the public report. So even if it was an honest math error, it can appear to others, like new potential residents, as if the facility didn't report accurately. Please, encourage your team to take a few extra minutes to verify totals and catch any avoidable issues before submission. This helps ensure your data is complete, valid, and reflects the good work you're doing. This is the format in which your facility's quality measurement program data will appear in the public report. In this example, the facility did a great job trying to report all their data, but you'll notice a few categories show RNV, which stands for Report Not Valid. This happened in areas like direct care staff training and antipsychotic medication use. And here's the thing, it wasn't for lack of effort. These invalid results usually stem from small, avoidable issues in the way the data was entered. That's why we strongly recommend using the data worksheet. Think of it as your spell check for QMP reporting. It helps you catch those little snags before they affect your results. A few extra minutes now can save a lot of confusion later and make sure your efforts are fully reflected in the report. Let's make sure your hard work counts, literally. This slide is a quick start guide for providers who are ready to submit their 2025 quality metrics data in January 2026. Let's walk through the 4 basic steps. 1. Print the 2025 QMP data worksheet. We recommend printing a hard copy so staff can gather and double-check the data offline before entering it into the portal. Save this document so you have a record of the data you've reported. 2. Complete the data worksheet. This can be a team effort. Nurses, administrators, or designated staff can help fill in each metric area accurately. 3. Open the reporting link. The online link for submission will go live on January 1, 2026, and it will be shared on the program website and via a provider alert, so make sure you're subscribed to receive those alerts. 4. Enter your data into the system. Once you have all your information filled out on the worksheet, simply transfer it to the online form. You can always find more guidance and reporting tools at the program website. And an important note, you can write qualitymetrics.acuity at odhs.oha.oregon.gov after entering your data to verify your data has been received. Quality measurement data reporting is tied to the facility's license, not the campus or the organization. If your organization operates multiple licensed facilities on one campus, for example, a memory care and an assisted living facility, each must submit its own set of data. This affects how you report retention of direct care staff and timeliness of staff training for all staff. If staff work across both facilities, they need to be counted separately, once for each license setting. Plan ahead to ensure accurate, distinct data for each facility. Let's start with our first metric, retention of direct care staff. This one is all about stability. When direct care staff stay in a facility longer, residents benefit from more consistent relationships, better communication, and greater trust. That's why higher retention is a key indicator of quality. To report your retention rate, you'll need to track 3 things: the hire dates for all your direct care staff, how many direct care staff were employed for the full year from January 1 through December 31, 2025, and how many were employed on December 31, 2025. Using that data, the formula is simple. The number of direct care staff who worked all year divided by the total number of direct care staff you had at year end. This gives us a percentage that reflects how well your facility retained its core caregiving team throughout the year. Let's take a moment to clarify an important distinction that directly affects how you report on Metric 1, direct care staff retention. On this slide, we've divided staff roles into 2 main categories, direct care staff and non-direct care staff. This distinction matters because Metric 1 only includes direct care staff, those whose primary responsibility is to provide personal care services to residents. These personal care services may include assisting with daily activities like dressing, bathing, and toileting, administering medications, offering direct supervision and support, serving meals, but not cooking them. Universal workers are considered direct care staff and are defined in Oregon administrative rules as facility employees whose assignments include other tasks, housekeeping, laundry, or food service, in addition to direct resident services. Universal workers do not include administrators, clerical or administrative staff, building maintenance staff, or licensed nurses who provide services as specified in the administrative rules for assisted living and residential care facilities. On the other side, we have non-direct care staff. This group includes roles that support residents but do not meet the criteria for direct care. Think of administrative staff, maintenance teams, kitchen workers who only prepare food, and activity staff. These employees play vital roles in your community, but they are not counted in Metric 1. A common point of confusion is around licensed nurses. Unless they are working in a direct care role as defined by OAR 411-054-0034, they are not included in Metric 1 either. Remember, the goal of this metric is to understand the stability of the caregiving team that residents rely on most directly for day-to-day care. If you're unsure which roles to count, refer to your staffing assignments and whether personal care is a central part of that employee's daily duties. Let's bring the retention formula to life with a practical example. Facility A has 40 direct care staff on December 31, 2025. Of those, 25 were employed continuously since January 1, 2025. To calculate the retention rate, divide the number of direct care staff employed for the full year by the number of direct care staff on payroll as of December 31, 2025. In this example, it's 25 divided by 40, which equals 64%. That means 64% of the direct care staff were retained throughout the full calendar year. Remember, the number of direct care staff who worked all year or longer must be less than or equal to the number of direct care staff on December 31, 2025. So that's how you calculate the retention rate for direct care staff. Accurate tracking of hire dates is essential for this metric. Now, let's move on to metric 2, compliance with required staff training, which connects to retention but tells us something different: whether your staff receive the training they need to provide safe, quality care within required timeframes. Metric 2 focuses on compliance with staff training requirements. This means ensuring that every staff member completes all required trainings on time, according to their role and responsibilities. To stay compliant, facilities need a reliable system for tracking hire dates and monitoring training completion dates. One tool that can help is the optional training tracking spreadsheet available on the program website under the Quick Links section. It's not required, but it can make organizing and reviewing training records a lot easier. Another set of tools to assist with this metric are the tables 5 through 8 in the provider instructions that summarize the trainings due for direct and non-direct care staff and the additional training requirements for staff in memory care endorsed facilities. To wrap up this section, I'd encourage everyone to ask, what is your system for tracking staff training records and ensuring compliance? Facilities that do this well tend to avoid last-minute scrambles and are better prepared during inspections. Remember how we noted the distinction between direct and non-direct care staff when discussing metric 1? That distinction is important for metric 2 as well. For the on-time training metric, facilities must report compliance separately for direct care and non-direct care staff. That means your tracking systems, whether manual or electronic, need to clearly identify which staff fall into each category. This ensures the data reflects the unique training expectations for each role and helps us monitor how well facilities are supporting all team members in meeting their annual training requirements. Let's walk through how to calculate training compliance for metric 2. In this example, we're looking at Facility B in 2025. They employed a total of 50 staff at some point during the year. Of those, 45 completed all required training on time. So the compliance rate is calculated as 45 divided by 50 equals 90%. Here's the quality check. The number of staff who completed training on time must be less than or equal to the total number of staff employed at any time during the year. So don't just count current staff or only those still active at the end of the year. You're looking at everyone who worked at the facility at any point in 2025, even if they only worked for a short period of time. That's why having a solid system to track hire dates and training completion is so critical. Let's walk through this real-world example to clarify how we determine whether a newly hired staff member meets training compliance by the end of the reporting year. In this case, a direct caregiver is hired on December 4, 2025. They complete their pre-service orientation just 2 days later on December 6. However, by December 31, they haven't yet finished their 30-day direct care staff training because they're still within their first 30 days. So the key question is, did this caregiver meet training requirements by the end of 2025? The answer is yes. Why? because the caregiver was hired late in the year and completed their pre-service orientation on time. Even though the 30-day training isn't done by December 31, they're still within their training window, so they're counted as compliant for the purposes of this metric. This example illustrates why it's so important to look at timing and context, not just whether all training is fully complete. As long as staff are meeting deadlines based on their hire date, they're considered compliant. Let's try another example. In this case, a direct caregiver is hired on October 2nd, 2025. They complete their pre-service orientation on October 6th, which is fine, still within the first week. They also finish their 30-day direct care training, but not until November 3, 2025. Did this caregiver complete their trainings due within 30 days on time? No, they did not complete the required trainings on time. November 3 is 33 days after the date of hire, which means they missed the required 30-day training deadline by 3 days. So even though the training is eventually completed, this caregiver would be marked as non-compliant for the metric because they did not complete all the required training within 30 days of hire. This example highlights the importance of tracking training deadlines closely. Even small delays can affect compliance rates, so having a reliable system for reminders and follow-up is essential. Let's try another example that examines annual in-service training, which is a recurring requirement after the first year of employment. The caregiver in this case was hired on December 12, 2024. They completed their annual in-service training on December 9, 2025. So the question is, did they complete their annual training on time? The answer is yes. Even though they were just a few days away from their anniversary, the caregiver met the requirement because the training was completed before their December 12 hire date anniversary. This is a good reminder that for annual in-service training, staff have a full 12 months from their hire date to get it done. As long as they complete it on or before their anniversary, it counts as compliant. This is a great example of proactive tracking and scheduling. Encourage your teams to plan ahead so they're not scrambling to get these done at the last minute. This final example brings together several key points about how training compliance is calculated. In this case, the facility employed 37 staff members during the year 2025. That number includes both direct and non-direct care staff, and importantly, it also includes staff who left before the end of the year. So when calculating your training compliance rate, you're not just counting who's still employed in December. You're looking at everyone who was employed at any point during the year. Out of those 37 employees, 33 completed all required training on time, based on the rules and deadlines tied to their hire date and role. This would result in a compliance rate of 33 divided by 37, which is roughly 89%. This example reinforces that you must include everyone employed at any time, not just year-end staff. You must verify whether each person completed the correct training within their required time frame, and whether that's pre-service, 30-day, or annual in-service training. Tracking and documenting this consistently throughout the year is essential. It's much easier to stay on top of it monthly than trying to piece it together at year-end. Let's continue with the data from example 4 and take a closer look at how we calculate training compliance for direct care staff specifically. What percentage of direct care staff at this facility completed their required training on time? We're looking at 25 direct care staff who were employed at some point during 2025. Out of those, 22 completed all required training on time. To calculate the compliance rate, we divide 22 by 25, which gives us 88%. So 88% of direct care staff met their training requirements within the designated time frames. Let's finish our breakdown of example 4 by looking specifically at non-direct care staff training compliance. What percentage of non-direct care staff at this facility completed their required training on time? In 2025, the facility had 12 non-direct care staff at some point during the year. Out of those, 11 completed their training on time. To calculate training compliance, we divide 11 by 12, which equals 92%. So 92% of non-direct care staff were in compliance with training requirements. Compared to the 88% compliance rate for direct care staff we saw earlier, this facility had slightly higher training completion among their non-direct care workforce. This kind of data can be very useful internally. If you're seeing gaps or trends by staff type, it can guide where to focus training reminders or system improvements. For example, direct care staff have heavier onboarding needs that make training timelines more challenging. Always remember, the compliance calculation is based on the total number hired at any time during the year, not just current employees. As you complete the on-time staff training metric, here are a few important reminders to help ensure accuracy. First, be sure to include all staff who were hired by your facility at any point during 2025, even if they only worked for a short time. This includes temporary, seasonal, or part-time hires. If they were hired in 2025, they should be counted. Next, the number of staff who completed their required training on time must be less than or equal to the total number of staff hired. That's because only hired staff can complete training, and some may not complete it on time or at all. Finally, keep in mind that the total number of staff hired throughout the year will typically be larger than the number of staff working at the end of the year. This is because of turnover. Staff come and go, so your annual hiring number will reflect more people than your year-end headcount. These details are important for ensuring your facility's data reflects real staffing patterns and supports quality tracking across the state. Let's move on to metric 3, resident falls with injury, a critical indicator of resident safety and long-term care. Falls are one of the leading causes of injury among older adults in care settings. They can lead to hospitalization, loss of mobility, and even premature death. So tracking and reducing falls isn't just a regulatory requirement, it's essential to protecting quality of life. For this metric, facilities must track specific data each month from June through November 2025. Here's what you need to track: the number of residents living in the facility on the last day of each month. This gives us the population size used in the denominator of the metric. The number of falls with injury involving residents during the month. This includes any resident who is injured in a fall while living in the facility. The number of unique residents who fell with injury. And finally, how many residents fell more than once with injury in a single month. This helps highlight whether a single individual may be at repeated risk, which is important for care planning. This data helps identify patterns, like increases in falls during certain months or residents who need more targeted interventions. Most facilities are tracking this data using their incident reporting process. Now let's walk through an example of how to report resident falls with injury for a specific month. Here, we're looking at June 2025. At the end of June, there were 40 residents living in the facility. During the month, there were 5 total falls with injury. 3 different residents each had 1 fall with injury, and 1 resident fell more than once with injury during the month. This example helps distinguish between the total number of falls, which is a count of incidents, and the number of residents involved, which reflects how many people were affected. Here's how that example translates into the data you'll report. Total residents on the last day of the month, 40. Total number of falls with injury, 5. Total number of residents who experienced a fall with injury, 4. Number of residents who fell more than once with injury, 1. Let's wrap up metric 3 with a few key reminders to help you report data accurately. First, make sure you're reporting falls data for each month separately from June through November. Don't lump it all together. Each month gets its own set of data points. Second, The resident count you report on October 31 for metric 3, falls with injury, is the same number you'll use for metric 4, which we'll cover next. It's the same census snapshot, so be sure it's consistent. Finally, and this is big, set up a system to record falls data monthly. You are probably already doing this by reviewing incident reports regularly. Don't wait until the end of the year and try to piece it all together. Track the data in real time, ideally at the end of each month, to make sure it's complete, reliable, and ready to report. Keeping your data organized month to month helps ensure that what you submit reflects the real experiences of your residents and allows for better support, better planning, and better outcomes. Metric 4 tracks how often residents are prescribed antipsychotic medications for non-standard uses. It includes both scheduled, that is daily or regular, prescriptions, and PRN, or as-needed prescriptions. Antipsychotics are typically used to treat conditions like psychosis, severe mood disorders, and in some cases, nausea or vomiting. When used correctly, they can help people lead stable, fulfilling lives. But in 2017, when Oregon launched the Residential Quality Measurement Program, the legislature heard concerns that these powerful medications might sometimes be used inappropriately, to sedate or control residents rather than to treat a valid diagnosis. That's known as chemical restraint. Oregon law protects residents from this. Psychotropic medications must not be used to control behavior or restrict movement, unless there's a documented medical or psychiatric reason. For this metric, facilities must 1. Report the number of residents living in the facility on October 31, 2025. 2. Review each resident's records to determine who was prescribed an antipsychotic, either scheduled or PRN, who had a qualifying diagnosis that meets the exclusion criteria, such as schizophrenia or anxiety disorder. These cases are considered standard use and are excluded from the metric. Who was prescribed an antipsychotic without one of those diagnoses? This is the group counted for metric 4. This metric emphasizes the importance of thorough assessments, knowledge of residents' histories and preferences, and adequate staffing and training. Antipsychotic medications can be part of a person-centered plan, but only when used appropriately with clear clinical justification. This slide introduces an important distinction in how medications are used in care settings, especially when we think about quality and safety. Doctors typically prescribe medications for what we call standard uses. These are uses that are evidence-based. They've been tested through research for specific conditions. That's why they're considered safe and effective when used as directed. A standard use means the medication is being used to treat a condition that it's been shown to work for, like using insulin to treat diabetes or an antibiotic to treat a bacterial infection. On the other hand, non-standard use is any use that doesn't fit that description. Non-standard uses do not have the same level of evidentiary support. The visual here, trying to fit a square peg into a round hole, is a great metaphor. Just because a medication exists doesn't mean it's the right fit for every symptom or resident. Metric 4 is a count of residents who take antipsychotic medications for non-standard uses. You'll report the number of residents with scheduled and as-needed, or PRN, antipsychotics separately. Examples of non-standard uses include giving an antipsychotic to, attempt to manage wandering behavior, cause sedation or keep someone calm, or attempt to reduce fall risk. Let's focus on a key concept, exclusionary diagnoses. Metric 4 is designed to track the non-standard use of antipsychotic medications. However, certain medical conditions like schizophrenia or major depressive disorders are considered exclusionary diagnoses. That means if a resident has an exclusionary diagnosis, their use of antipsychotics is considered standard, and they should not be counted for this metric. Only residents without an exclusionary diagnosis are included in metric 4. To report accurately, use the tables in the provider instructions for data collection. Table 13 lists antipsychotic medications. Table 14 lists exclusionary diagnoses and variations. These tables are available under quick links on the program website. So even if a resident has a prescription for an antipsychotic, if they also have an exclusionary diagnosis, they should be excluded from the metric 4 count. That's why it's essential to check for exclusionary diagnoses first before reporting a resident under this metric. This measure is not defining standard or non-standard as all correct or incorrect. In Oregon assisted living and residential care facilities, residents choose their own healthcare providers like doctors or nurse practitioners. Individual decisions between a patient and their healthcare provider are complex. Assisted living and residential care facilities do not prescribe medications or employ the staff who do. Healthcare providers measure their patients' needs and decide what medication should be prescribed to their patients. What assisted living and residential care facilities do is monitor and report the effects of medications to the resident's healthcare provider. Assisted living and residential care facilities do not change, reduce, or increase medications. Rather, the facility has non-licensed, trained staff called medication aides who administer the medications to residents. The goal of collecting metric 4 data is to identify the use of antipsychotic medications so that an informed policy conversation can be had. There is a perception that there's a high rate of non-standard use, but is that accurate? Data collection on non-standard uses of antipsychotic medications in assisted living and residential care facilities serves as a critical tool for identifying any potential misuse. We can create targeted interventions and quality improvement initiatives to ensure the safe and effective use of antipsychotics in these settings and ultimately enhance the overall quality of care for residents. Now that we've covered the background and purpose of metric 4, let's walk through how to collect and report the data accurately. This is a point-in-time measure. Everything you report should reflect what was true on October 31, 2025. Here's the step-by-step process. Number 1, start with your October 31 census. Count all residents living in the facility on that day. This is the same number you'll use for October's metric 3 resident count. 2, check the medication administration records. Identify how many residents have a current prescription for an antipsychotic. You'll find a list of qualifying medications in Table 13 of the provider instructions. 3, review diagnoses. Look at each resident's medical chart. If they have a diagnosis listed in Table 14, for example, schizophrenia or Tourette's, their antipsychotic use is considered standard and should not be counted in this metric. These are known as exclusionary diagnoses. 4, count scheduled antipsychotic use for non-standard reasons. These are residents who receive antipsychotics daily or regularly and do not have an exclusionary diagnosis. 5, count PRN antipsychotic use for non-standard reasons. Include residents prescribed antipsychotics on an as-needed basis, even if the medication wasn't administered. If it was prescribed and the resident has no exclusionary diagnosis, it counts. The goal of this metric isn't to eliminate antipsychotic use. Rather, it's to shine a light on non-standard use so facilities can review these cases and explore person-centered alternatives when appropriate. The quality check for metric 4 is designed to help ensure your data is internally consistent. You'll find this check directly on the data worksheet, which I recommend printing and using as your guide when organizing your responses and a way to retain a copy of your data. Here's how the data elements fit together. 4A is the total number of residents on your census as of October 31, 2025. 4B is the number of those residents who have a current prescription for an antipsychotic medication. 4C asks, Of those reported in 4B, how many have a diagnosis listed on Table 14? These are the excluded diagnoses that could make antipsychotic use standard and not counted in this metric. 4D is your key number. Subtract 4C from 4B. This gives you the number of residents using antipsychotics for non-standard reasons. In other words, they're prescribed an antipsychotic but don't have an exclusionary diagnosis. 4E is how many of those in 4D have a scheduled antipsychotic prescription. 4F is how many of those in 4D have a PRN antipsychotic prescription. Each of these data points feeds into the quality check shown on the slide. If the math doesn't add up, or if 4D is greater than 4E or 4F, that's a red flag to double check your counts. Let's walk through a real-world example of how metric 4 data looks once it's been collected. In this case, the October 31, 2025 census shows 52 residents living in the facility. Of those, 14 residents have a current prescription for an antipsychotic medication. When reviewing diagnoses, 10 of those 14 residents have a condition that appears on the exclusions list, so their antipsychotic use is considered standard and not counted for this metric. That leaves 4 residents whose antipsychotic prescriptions are considered non-standard and counted for this metric. These are residents who don't have an exclusionary diagnosis and are prescribed an antipsychotic. In this example, all 4 residents with prescriptions for non-standard antipsychotics have scheduled and, as needed, antipsychotic prescriptions. Remember, to help ensure accuracy in your responses, the following should hold true. 4D should be less than or equal to 4E, and 4D should be less than or equal to 4F, and 4E plus 4F should be at least equal to 4D, but could be as large as 2 times 4D. In this example, 4D is equal to 4E. Check. 4D is equal to 4F. Check. 4E plus 4F is 8, 2 times 4D. Check. This passes our quality check, and this data is valid and ready to report. Let's test your understanding with an example that has an error. Here's a data set submitted for metric 4. Something's not right. Can you find the mistake? Take a moment to look closely at the numbers. 10 residents have an antipsychotic prescription. 10 residents are reported with exclusionary diagnoses. But also, 10 are reported as having scheduled antipsychotics for non-standard use, and another 10 are reported as having PRN antipsychotics for non-standard use. Think about how these numbers relate to each other. According to the logic we just reviewed, how can someone be counted in both the exclusion list and the non-standard use fields at the same time? Here's the issue. You cannot report residents with non-standard use if all of them had exclusionary diagnoses. In this case, if 10 residents have a prescription for an antipsychotic, that's 4B, and all 10 of those residents have a condition on the exclusions list, that's 4C, then there should be 0 residents reported for non-standard use in 4E and 4F, not 10. This example helps highlight a common reporting error. Sometimes facilities mark every box without checking for internal consistency. Always double check that the math and logic match the definitions we've discussed. Let's put your observation skills to the test with a real-world example. This data set was submitted for metric 4, but something doesn't add up. Can you find the mistake? Take a moment to review the numbers. 8 residents have a prescription for an antipsychotic. 4 residents are reported as having a diagnosis from the exclusions list. Now, think about how these numbers should relate. Based on what we've covered, what's off? Let's walk through the issue together. If 8 residents are prescribed an antipsychotic, and 4 of those have a condition that qualifies them for exclusion, that leaves 4 residents whose use must be reviewed for non-standard use. But only 2 residents are reported for scheduled non-standard use, and none are reported for PRN as needed non-standard use. Here's the key logic. The number of residents with non-standard antipsychotic use, scheduled and PRN combined, must equal the number of residents who are not excluded. In this case, 4 residents need to be accounted for, but only 2 are shown. So how can this be corrected? It's possible that all 4 residents have non-standard use, split between scheduled and PRN, but that's not what the data shows. The facility should revisit the entry and ensure that all 4 residents are accurately reported across the 2 categories, scheduled and PRN. Encourage staff to review the logic step by step. Mistakes like this are common and fixable. To wrap up our guidance on Metric 4, I want to highlight 2 tools that can really help you stay accurate and confident in your reporting. Tables 13 and 14 in the provider instructions. Table 13 lists all antipsychotic medications alphabetically. It includes both brand names and generics, so you won't miss a medication just because it's written differently in the MAR. If a resident is prescribed a medication on this list, you know it qualifies for review under Metric 4. Table 14 provides a list of exclusionary diagnoses. If a resident has a diagnosis from this list, such as schizophrenia, major depressive order, or Tourette's, they are excluded from the Metric 4 count, even if they are prescribed an antipsychotic. This is because their use is considered clinically standard. One helpful reminder. Sometimes diagnoses don't appear in the chart with the exact language used in Table 14. So if a doctor documents paranoid type delusional disorder instead of schizophrenia, you may need to use professional judgment and consult with clinical staff or records to confirm whether it aligns with the exclusions list. Using these 2 tables correctly is the key to getting Metric 4 right, and to making sure that your data accurately reflects the quality of care provided in your facility. Let's close out Metric 4 with a few key tips to make sure you're getting the data right and submitting clean, consistent numbers. First, always consult your 2 best resources, Table 13 for the list of antipsychotic medications, and Table 14 for the list of exclusionary diagnoses. These tables are your go-to tools for determining whether a resident's antipsychotic use should be reported as non-standard. If the resident has a diagnosis that appears on Table 14, you do not count them in the Metric 4 total, even if they're on an antipsychotic. That use is considered standard. Second, a reminder about consistency across metrics. The October 31 census you report for Metric 4 should match exactly with the census reported for October falls in Metric 3. Both metrics rely on the same point-in-time snapshot of your resident population, so those numbers should align perfectly. The image of a hammer and a nail is here for a reason. When it comes to Metric 4, the goal is to nail it. Get the numbers right the first time by following the step-by-step guidance and using the tools provided. Let's take a closer look at Metric 5, Resident Satisfaction, which applies to all ALF and RCF, and includes a family satisfaction component for memory care communities. Tracking resident satisfaction helps us understand the quality of care from the people who matter most, the residents themselves. Research consistently shows a strong link between how satisfied residents are and the overall quality of care and services they receive. That's why this metric is so valuable. It allows facilities to reflect on how residents and families experience care, and to use that insight to make improvements where needed. Facilities use a standardized survey tool called CoreQ to measure satisfaction. CoreQ was developed through a national collaboration led by experts like Dr. Nicholas Castle, with support from the American Healthcare Association, the National Center for Assisted Living, providers, satisfaction vendors, and importantly, residents. It includes 4 questions and is simple to administer, designed for long-term care settings, and independently validated to reliably capture meaningful feedback. Using CoreQ ensures that satisfaction is measured consistently and comparably across facilities. What to report for metric 5? The number of residents or family members who responded to the CoreQ survey. Your facility's participation rate, which gives us a sense of how representative the results are. For memory care communities, be sure to include data from both the resident and family CoreQ surveys. Now, let's take a look at the CoreQ Resident Satisfaction Survey, which forms the basis for one of our key metrics. Each facility must contract with a CoreQ-approved customer satisfaction vendor to administer the survey once a year. These vendors are trained and certified to use the CoreQ questions and reporting format, helping ensure the data is consistent and comparable across facilities. You can find CoreQ vendors at http://coreq.org. Residents are asked 4 questions. How likely they are to recommend the facility to friends and family. How would they rate the staff overall? How would they rate the care they receive? And how would they rate the food? Each question is answered using a 5-point scale from poor equals 1 to excellent equals 5. Resident survey answers are reported by a count of responses, not percentages of responses. Reporting percentages will result in data that is reported, but not valid. The resident satisfaction survey is meant to be anonymous. Please ensure that your process allows residents to complete and return their surveys with the reassurance that their answers are anonymous and confidential. This helps protect resident privacy and supports the integrity of the feedback. In addition to the resident responses, each facility also needs to report some important background information about how the CoreQ survey was administered. Here's what you'll need to track and report. How many residents received the survey? How many returned it with at least 1 question answered? How many completed all 4 questions? The name of the CoreQ approved vendor your facility used, and the method used to administer the survey, whether it was done in writing, by phone, in person, online, or a combination. These details help ensure the data is interpreted correctly. For example, knowing whether the survey was done in person versus online can help offer context for response rates or trends in satisfaction. Be careful not to confuse received with responded or completed. These are all separate counts and help us understand overall response quality and participation rates. Make sure your vendor provides this data back to you in a way that's easy to extract and report. Most approved vendors are used to working with these requirements. If you've had challenges with the survey response rates in the past, you're not alone. We'll offer some best practices later to help improve resident participation. The family survey is a new requirement for memory care facilities only. The family survey is in addition to the resident survey. Here's how the family satisfaction survey will work. Using the facility's CoreQ vendor, the family survey must be distributed to the primary representative listed on the resident's contact sheet. The survey must also include this instruction. Family members should only respond if they have visited the facility recently enough to provide an informed opinion. This helps ensure feedback reflects actual experience and not outdated impressions. Memory care facilities are responsible for submitting the following information. The number of family members who received the survey. This tells us the total distribution count. The number of family members who returned the survey. A return counts even if they answered just 1 question. The number of surveys completed in full. That's the total number of respondents who answered all Core Q questions, the name of the Core Q vendor used to administer the survey, and the survey administration method. This refers to how the survey was delivered, by mail, phone, online, or a combination. Family survey results will be included in the public report right alongside resident satisfaction results, so it's essential that the data is both complete and based on valid responses. To make the family survey successful, prepare families by providing advance notice of the survey and review their contact information ahead of time to support accurate and timely reporting. In 2024, over a quarter of all eligible facilities had their Metric 5 data excluded due to reporting errors or missing data. That's 131 invalid submissions and another 24 that didn't report at all. 155 facilities whose resident voices were missing from the final report. These issues often stem from simple mistakes: sending surveys but not getting responses back, mismatches between the number distributed and received. It's especially common in smaller RCFs and memory care settings where collecting responses is more challenging. Some of these issues can be resolved by checking your math. If you say you distributed 20 surveys but received 25 responses, that's going to cause your data to be flagged. The data worksheet can help you do this. For memory care settings, we're especially hopeful that the new 2025 Family Survey will help increase valid responses from populations where residents may not be able to self-report. With better use of tools, clearer guidance, and the added family output, I'm optimistic we'll see a big increase in valid facility level data next year. In this section, we'll explore Metric 6, Administrator Tenure. This metric helps us understand leadership stability at licensed care facilities, which can have a direct impact on care quality and staff morale. This metric isn't just a bureaucratic checkbox. It reflects leadership stability, which has a ripple effect across the entire facility, from staff retention to how safe and satisfied residents feel. It also helps consumers make informed decisions. This metric looks at two aspects: the length of service of each administrator, and how many individuals held the administrator role during the year. This gives a clear picture of how stable or turbulent a facility's leadership has been. The good news is, you don't have to report anything new. ODHS collects this information automatically through the Administrator Reference Summary Form, the ARS, you already submit each time a new administrator starts. That said, accurate ARS submissions are critical for this metric to reflect reality. Metric 6 is calculated using records the department already maintains, but there's one key step for providers. The only data you'll need to enter for this metric is the name of the administrator of record as of December 31, 2025. This should be the person officially designated and responsible for operations on that date. This designation must be on file with the department through Form SDS 0566 Administrator Reference Summary, which must be submitted by email or fax when a new administrator is hired. If the form isn't submitted or approved, we may not be able to match tenure data to your facility correctly, so it's important that this step is completed and up to date. This example walks through how ODHS calculates cumulative tenure for administrators using ARS records. We start with Jane Doe, who was hired as administrator on January 15, 2023. She served continuously until taking a leave of absence from June 12 to July 25, 2024. After that, Jane returned to work on July 26, 2024, and stayed through the end of the reporting period, December 31, 2025. So, how does ODHS calculate cumulative tenure? We break it into distinct work periods. The first is from January 15, 2023 to June 11, 2024, right before the leave starts, which totals 514 days. The second starts on the day Jane returns, July 26, 2024, and runs through December 31, 2025, 524 days. Together, that's 1,038 days of active service. We then convert that into months. So 1,038 days divided by 30.4, the average days per month, gives us 34.1 months of cumulative tenure. This calculation ensures that short-term leaves don't penalize administrators unfairly while still focusing on actual time served. This slide builds on the previous example, but here we're focusing specifically on uninterrupted tenure. Jane was hired on January 15, 2023, and like before, she took a leave of absence from June 12 to June 25, 2024. She returned on July 26, 2024, and continued working through December 31, 2025. For uninterrupted tenure, ODHS looks only at the most recent stretch of time where the administrator worked continuously without any breaks. In this case, that period begins on July 26, 2024, the day Jane came back from her leave. From that point through the end of 2025 is 17.5 months of uninterrupted service. So even though her cumulative tenure is over 34 months, her uninterrupted tenure is only 17.5 months. This distinction is important for any metrics or benchmarks that focus specifically on recent continuous service, like assessing leadership stability. This example helps illustrate how ODHS identifies and counts unique administrators of record during the reporting period. Let's look at facility XYZ in 2025. First, John Smith served from January 1 to March 15. Then, Jane Doe took over, serving from March 16 to September 30. Finally, Alex Johnson stepped in from October 1 through December 31. Even though each of these individuals served for multiple months and none overlapped, we still count each one as a unique administrator of record for the facility. So the total for facility XYZ in 2025 is 3 unique administrators. This measure helps us understand turnover patterns and leadership stability. Facilities with a higher number of administrators in a single year may face challenges with continuity in operations, while lower turnover often correlates with stronger quality outcomes. The data for the 2025 Quality Measurement Program will be reported online using a secure link. This link will be published in a provider alert in December 2025, so please keep an eye out for that announcement. If you're not already subscribed to receive provider alerts, now would be a good time to sign up. That alert will include the official reporting link and any final reminders you need. To make the data entry process smoother, we strongly recommend that you use the 2025 Quality Measurement Program data worksheet ahead of time. This worksheet mirrors the reporting form and helps you collect and organize your information in advance so that when the reporting link goes live, you're ready to go and can enter the data in one sitting. Once you enter your data into the online form, you will not be able to retrieve it later. That means it's essential to keep an accessible copy of all submitted data for your records. The data worksheet is an easy way to retain your data. Although the official deadline to submit data is January 31, 2026, we encourage providers to report as early in January 2026 as possible. Submitting early allows time to confirm that your data has been received and is accurate. Providers who submit early may email qualitymetrics.acuity@odhsoha.oregon.gov to request confirmation of receipt and accuracy. Early submission gives your facility the opportunity to correct any errors and ensure your quality data is represented correctly. Facilities that do not submit data by the deadline will be listed in the annual report to the legislature and may be subject to penalties. Use the reporting link that will be published in a December 2025 provider alert to submit your data. Resources are available to assist with reporting on the Quality Measurement Program website. These include the the provider instructions for data collection 2025, data collection link instructions and screenshots, 2025 Quality Measurement Program Data Worksheet, the provider training handout, that's these PowerPoint slides and notes, and the Staff Training Tracker, an optional tool to track staff training compliance for Metric 2. This last slide is designed to help you walk away with a clear list of reporting essentials. Remember to use the QMP data worksheet before entering data. Track staff, training, falls, medications, surveys, and administrator tenure. Check your math. Remember, logic errors result in data that's reported but not valid. Submit your data by January 31, 2026. Contact us if you're unsure or need confirmation. Keep a copy of your submitted data for your records. Thank you for viewing this training on the 2025 Quality Measurement Program. Your participation and attention to detail in this process are essential, not just for compliance, but for improving the quality of care residents receive every day. If you have questions after viewing this webinar, or if anything comes up while you're preparing or submitting data, please don't hesitate to reach out. My direct contact information and the Quality Metrics inbox are provided on the slide. We're here to support you and your teams, whether it's technical assistance, clarification on a metric, or help navigating the reporting system. We want this to be a process that supports your work, not a burden. Thank you again, and thank you for the care and dedication you bring to Oregon's long-term care communities.